Good evening. Welcome to Facebook Live tonight. I'm really excited to share the next 30 minutes with you to talk about fertility treatments. And I'm hoping to run through some of the basic information in the next 10 to 15 minutes, and then we'll have plenty of time for questions. My name is Andrew Hedges. I'm the Clinical Director of Hunter IVF. I'm actually one of the founding directors of Hunter IVF, and we've been in the Hunter Valley for nearly 20 years. Our clinic's located in the Hunter Valley, and we look after patients really right up the north coast through the northern rivers, up through the New England, and as west out past Gunnedah. So it's a very exciting place to work. We have a fantastic team, and we're very proud to deliver absolutely first-class care to all of our patients here in the Hunter, and we're proud to be part of IVF Australia. We have a slightly unique program where we offer standard IVF, but we also offer light IVF, and that's just increased the accessibility and affordability for patients, and it works beautifully. I'm very happy to answer any questions along the way, and so I encourage you to ask as many as you like. And if we need to, we can extend our 30 minutes a little bit longer just to sort of cover any other questions that you might have. And if we run out of time, there's always 1-800 and our websites to get further information. So I'd like to talk about fertility treatment and just some of the options that are open. And obviously a lot of you will know a little bit about IVF, and you may have heard about other treatments. But first of all, I just wanted to cover off some of the reasons why people might need fertility treatment in the first place. And you might be in that position yourself, thinking about, well, is fertility treatment right for me? And what are my options? And I guess the first question is, well, who needs fertility treatment? What are the reasons why people might need help? And obviously, fertility problems are common. 1 in 20 people have difficulty with fertility. It can be male factor, it can be female factor. And part of the journey, I think one of the initial really important steps is getting a referral and seeing a fertility specialist who will go through your history in detail and look at what sorts of tests have been done previously, what sort of issues you've had, what sort of, if you've had any investigations, surgical investigations in the past. It's really important to be able to bring all that information and bring photos if you've had laparoscopies, etc. But if we start with IVF, what does that really mean? Well, IVF stands for in vitro fertilization, and in vitro means, or vitro means in glass. And that's because when we do IVF, fertilization occurs outside of the body, and traditionally it was in glass test tubes. And that's opposed to in vivo, which is in the body. And with IVF, our main aim is to actually fast forward that whole front end of fertility treatment, actually move to putting a fertilized, growing embryo back inside the uterus. Now, just because we're called Hunter IVF or IVF Australia, it doesn't mean that we just do IVF. And for some couples or some women, they might have difficulties with ovulation where they're just simply not releasing an egg every month. And others might have problems with endometriosis or blocked tubes, or there might be problems with sperm and male factor infertility. In fact, about half the time, male factor is either the major problem or at least a contributing problem for fertility. So part of the initial investigation is to get some idea about where the roadblocks might be and whether there's simple things we can do to overcome those roadblocks. So I've mentioned ovulation. So in a given month, what normally happens is that if you think about your ovaries as almost like your bucket of eggs, in the few days leading up to a period, you sort of reach into that bucket of eggs and you've got that little group of follicles or eggs that you're going to use for that particular cycle, that month. And in the first few days of the cycle, all of them begin to develop, and then one of them becomes dominant, suppresses all the others. And that's the one that goes through, and hopefully mid-cycle, you have a release of hormones which triggers ovulation. And that egg is released from the ovary and it travels into the fallopian tube. And if you have sperm is present at the right time, have sex at the right time, or then sperm travels from the uterus up into the tube, and that's where fertilization occurs. Over the next 5 days, the little embryo now, the fertilized egg, travels down to the womb, and if everything's right, will implant. So if there's a problem with ovulation, some of the simple treatments might be using medications to actually help you ovulate. Common ones are medications like Clomid, another one called letrozole. And both of those medications work on little receptors in the brain to encourage you to produce more of the hormones that stimulate your own ovaries to work. And that chief hormone is follicle stimulating hormone. And it's the same hormone that we talk about with IVF. And I'll talk more about that in a moment. So ovulation induction with medication is a relatively simple treatment, which isn't particularly invasive. We'll often watch how that's going, and we can check to see if you've ovulated. I'm sure many of you have apps. When I ask my patients about apps, it's more a case of how many apps have you got that tell you whether ovulation is occurring. And those apps just work on roughly how long your cycle is, because the key thing is that we know that you ovulate about 14 days prior to your period. So if you've got a longer cycle, then your ovulation will be a bit later. Some women will also monitor whether they're ovulating by using some test kits looking at the surge of hormone that triggers ovulation, called luteinizing hormone, or LH. And you can buy those tests from the chemist or from supermarkets, and you can test around the time when you think ovulation is occurring to see the surge in hormone that tells you that ovulation is occurring. Sometimes we will do other treatments, for example, intrauterine insemination. We'll often combine that with ovulation induction, and that's where we put a prepared sample of sperm inside the uterus at the right time. So we're really trying to get all those ducks lined up so that we've got sperm exactly where it needs to be at the right time. There are some women where that really helps a lot, and those are women who might have had treatment to the cervix for precancerous cells or whatever, and their cervix has been damaged a little bit and it doesn't produce the sort of delicate mucus that it needs to. And so sometimes it's difficult for the sperm to make it into the womb. So intrauterine insemination is quite handy in that situation. There are other women where their husband or their partner might be away. I mean, you know, fly in, fly out's common these days. If you talk to colleagues in Canberra, half of them are fly in, fly out, and so that the partners can freeze sperm, and then we can use it with intrauterine insemination. Also, single women who will often use intrauterine insemination, or same-sex couples. So those sorts of treatments are really handy as well. There are more exotic forms of ovulation induction when those oral simple treatments aren't working. And we actually use the same drugs that we use for IVF to directly stimulate the ovaries to produce eggs. The trouble is it's really tricky because sometimes it's hard to just get that one egg that we want to be released. And what we really want to avoid is multiple pregnancies. So we use that carefully. So what are the other reasons? We talked about ovulation being a problem. Other ones are surgical problems like endometriosis, which can really create havoc with the ability to construct a really healthy lining of the womb so that embryos can implant. Things like fibroids and polyps are other sort of structural problems which might interfere with fertility, and sperm. So for some couples, the sperm is a really major issue, and there are lifestyle things that we can do, which like things like lifestyle modification, which help for both of you, like reducing alcohol, smoking, sometimes some occupation exposure to things like chemicals and fungicides and pesticides, which can be a problem. And so lifestyle modifications help, but sometimes it just doesn't work, and we need to do IVF to be able to bypass that interaction of the sperm and the eggs and actually put a sperm inside the egg. So let's just talk about IVF for a minute, because I just want to explain what that means, what that cycle means. So I mentioned before that we're actually fast forwarding to a point where we're actually getting a fertilized embryo and putting it inside, a growing embryo and putting it inside the uterus. So in order to do that, we need to take control of that menstrual cycle for that month. And I mentioned to you before that little group of eggs that are coming through. With IVF, we're actually using an injectable form of follicle stimulating hormone to encourage that whole group of eggs to come, or follicles to grow through that, so that we can collect the number of eggs. The whole process usually starts with day one of your period, and there are lots of different forms of FSH, or follicle stimulating hormone, but I just want to show you one of them, just so you know, because I think a lot of people worried about, well, what does this really mean? What do these injections look like? And in fact, one of the advances that there has been in IVF treatment is the development of really nice delivery systems, and they all have what's almost like a little diabetic pen. So I'm going to show you one here. This medication is a little IVF pen, and the needle, you can see, is tiny. So that's my little finger, and that's it, and it is fine. This one has a dial at the back, and you can dial up the dose that we tell you to, and then you actually give that to yourself each day. So normally you have daily injections of that follicle stimulating hormone, and you have a second medication whose job it is to stop ovulation during that month. And that's really important, because the last thing we want to do is have a nice group of growing follicles and then find out that your body sort of overrides it, decides it wants to ovulate now. We organise the egg collection, and then there's nothing to collect because they've all ovulated. So the medications to stop ovulation are a major advance in IVF, and they're really important. So those two medications are given daily, and we can monitor the progress of that stimulation with ultrasound and blood tests. And the ultrasound is done transvaginally or internally. And that's another important advance too, because the little transvaginal ultrasound is a higher frequency scan, which gives us really, really good detail, but over a short distance. And the really good thing about fertility treatment is that the ovaries, as they're growing, they're sitting right down behind the uterus next to the vaginal wall. They're almost right next to the vaginal wall. So we can get really good detail over that short distance, and we can see the little follicles as they're growing and count the number of them. And the other thing that happens as the follicles develop is that they will produce some estrogen, so we can actually look at the rising level of estrogen. And once we think we're at the right place, we've got a nice group of follicles, we've got a really nice estrogen level, then we can then time the egg collection. Now, we prepare for egg collection by giving a trigger injection, and that trigger injection does exactly that. It triggers ovulation. It helps mature the little follicles and the egg come away from the wall. And if we waited long enough, you would actually ovulate spontaneously. But we time that egg collection at around about usually 36 hours after the trigger injection. So that timing is really important. The egg collection itself happens either in a minor procedure room or in the operating theatre, and you're either asleep or very comfortable. And once again, we use that little transvaginal ultrasound probe, this time with a little needle guide fitted to it. And that guide, we can see very clearly the track that the needle passes on the ultrasound, and we can see each of the follicles. We can pass a very fine needle through the vaginal wall into the ovary, and usually through that single puncture, we can drain all the follicles in one ovary. So that means going from follicle to follicle, aspirating the fluid, and then giving that to the biologist who's in theatre with us, who will search through the fluid and tease out the eggs. So at the end of that procedure, you will know how many eggs you've got. We write that, or I will write that on your hand. And then on the same date, your partner will produce a sperm sample, and then we'll fertilize the eggs. Now, that's usually a fresh sample, but it might be a frozen sample if your partner can't be there, or it might be that it's frozen sperm because we're using donor sperm or whatever. And that fertilization happens in the lab. There are two ways that we fertilize eggs. One is by just putting a population of sperm with each individual egg, and that's about 100,000 sperm, and they sort themselves out. And the other way is by actually injecting a single sperm into the egg to achieve fertilization. And about half of the couples will have ICSI, which is the injection one, and about half will have just standard IVF. And we choose that based on the sperm count, what the sperm is like. So if there's sperm problems, they're not swimming, there's antibodies, they've got problems with low counts, we'll often use ICSI. Whereas if the count's normal, we'll often use IVF. Now, the biologist will then grow those embryos in the lab, typically for 5 days. And at the end of those 5 days, we're hoping to have a blastocyst, which is an expanded embryo, which has two distinct parts. It's got an outer cell and an inner cell mass. And it's important that we need to have embryos at that particular stage or just before, and the biologist will pick the best one for embryo transfer. And if we're fortunate enough to have extra embryos of good enough quality that we can freeze, they'll be able to freeze those. Now, the embryo transfer, once again, that sounds a bit mystical, and anyone who's had it probably thinks, well, that's not a big deal, but it's actually a very, very important part of the process. It's important to have a full bladder for we do an ultrasound guided transfer, and the full bladder is important for two reasons. First of all, the fluid in the bladder acts as a window so that we can use an abdominal probe this time to get a good view of the womb, and we can see the canal that leads up to the womb, so we can see if there's any difficulties with getting smoothly through into the uterus, because it's very important to make it as atraumatic as possible. You should almost not feel it. And we create, no contractions or any bleeding or problems. And the other reason the full bladder is important is because it actually helps to flatten the uterus out, so it makes the passage of the catheter into the womb straight. Now, what we do on the day is this is a little embryo transfer catheter with an inner catheter. And I just want to show you that because it is actually really fine and small. It's quite flexible. But the important thing about this one is we can put a little bit of bend on it, so that if there is a bit of a difficult route to get up into the womb, we can actually help to guide it. So that goes through the cervix and sits just inside, just at the neck of where the womb joins the uterus proper. Once we've got that in the right place, then the biologist, in our case, which is just next door, and you can see all this on screens. We've got a screen for the ultrasound. We've got a screen for where the biologist is and what they're doing. They will use this little very, very fine catheter. Sorry, I'm just going to get that into view for you. It is very, very fine. It's about a little bit thicker than my fingernail, and it's very soft and very flexible. It's got a little stiffening here so that we can actually get it to where we've got to get it to. And the biologist will aspirate the embryo from the dish, and then they'll pop that through this outer catheter, or I will pop it through the outer catheter. And let me get that to the right position. Here we go. There's some little markers on it, so I can tell where I'm right at the end here. So I'm right at the end right now. And then on scan, you'll actually see the little catheter come out the tip of the outer catheter, and I can see on scan exactly where I want to put that embryo. There's a little syringe on the end of it, and I will put in about 5 microliters. It's a tiny little amount. There's a little air bubble, usually each side of where the embryo is, so you can see it on the ultrasound, but you can also see that little air bubble come out, so it shows us where we are. And then we take the catheter out. That's the embryo transfer. It's really important that you then carry on with whatever instructions you have, and usually that's some progesterone support, and continue that right up to the pregnancy test. And the pregnancy test is about 9 to 10 days after that embryo transfer. So I am going to go to some questions now and see if any of you have any questions. So I'm just going to have to scroll back a little bit and see where we are. I've got some good evenings. I can see some. I won't read out your name, but good evening to you too. I'm just going to go to the first question I can see there. I've just got to try and make them scroll down again. So what are the suggestions for women who have been told they have a luteal phase defect with a low progesterone and high estrogen? Well, in IVF, the luteal phase is pretty happily dealt with because we use some additional progesterone always really from just before we do the embryo transfer right up into the pregnancy test. For people who we really believe have progesterone deficiency in the second half of their cycle, it's possible to use progesterone supplementation as well. The easiest one is progesterone pessaries. Common pharmacies can provide them. There's one called Oropro, they're 200 milligrams, and commonly we'll use them once or twice daily. We can also then measure the level of the progesterone in your blood, which gives us an indication, and we really like to see the levels at around 30 or above, and we can tailor it from there. Another question I have is, what is the likelihood of us falling pregnant with our frozen embryos? And that's actually a really good question, because we look at that data all of the time. And I think if you'd asked me that question 10 years ago, I would have said fresh is always better. But now we know, because we've got such good freezing techniques and because we freeze good quality embryos, what we see year in, year out at all of our sites pretty much is that the pregnancy rate from our frozen embryos is almost the same as our fresh. So I don't think you have to be nervous about using your frozens at all. Okay, now I'm just going to have to try and get up to, I wonder if I can move those ones up or down. I'll just see if we can. Oh, there we go. Another question was, how many how many failed cycles on fertility medicine should be till we look into the next steps? That's a really good question, and it's one that we talk about quite frequently, just face to face in the rooms. And I think the answer to it is that it really is quite individual, and it comes down also to your wishes. And I'll just explain that a little bit more. I think if you are let's say you're a 26-year-old and you've got good ovarian reserve, and there's not really any obvious cause has been found, or maybe it is, it's ovulation, it doesn't really matter. But the reality is that you could try as long as you like. If you look at things like the data from intrauterine insemination, the pregnancy rates from intrauterine insemination are nothing like IVF. For women under the age of 35, pregnancy rates are for IVF 45, 55%. Depends on your clinic, depends on your own circumstances. And it depends, on your particular one. But intrauterine insemination, pregnancy rates are run around about 15% per go. And everyone says, well, why is it so low? Well, the reality is that for a fertile couple having sex at the right time, pregnancy rates are really only about 25%. So if you look at 3 good ovulatory cycles and you're not falling pregnant, then realistically, there may be something else going on. It might be time to think about what to do. But if you were a 40-year-old, I'd be thinking about moving ahead much quicker, because you just don't have the luxury of that month on month. So I think it's individual. I think that it's always worth considering things after 3 months, and you might consider you'll go another 3 months. But my advice would be, if you're at that sort of age where your ovarian reserve is lower, or age is not being your friend, then I would look at more effective treatments earlier. Now, I'm going to see if I can move up a little bit further. And okay, is there a BMI cutoff where IVF won't be performed? I guess the answer to that is no, but then it does depend on the programs. And there are a couple of important things. BMI does have an effect on pregnancy outcome. There is no doubt about that. And that goes for males as well. So if you're overweight and you're a male, it does actually affect your reproductive performance. And there's some good literature produced on that just earlier this year, and it almost was a linear relationship or inverse relationship between chance of falling pregnant and how big the measurement was around the waist. But there's another consideration with IVF, and that is that we have to do an egg collection. And if we're looking at it gets technically difficult if the BMI is quite high, and it's also a little bit more risky from the point of view of anesthetic, sedation, all that sort of thing. Some programs do. For example, I mentioned we do a light or a low stim IVF. In that situation, we do our egg collections in the outpatient department, just with a little bit of oral sedation and local anesthetic. So we do have a cutoff for BMI there, and that's at 35. And it's because we have to just be really safe. If we have an issue, we've got to be able to manage things safely, but also it just gets more technically difficult, more painful if the ovaries are further away. So those people need to do standard, but there is not an actual cutoff for BMI. Now I'm going to go down. Yeah. Another question which was sent in earlier was about insulin resistance, and can it contribute to fertility? And the answer is yes. So insulin is produced. Insulin is a hormone that you produce to help you utilize glucose, and it helps you to move glucose from the bloodstream into cells. It's a very important hormone. For some women, they have what's called insulin resistance, and that means that they need to produce more insulin to be able to utilize their glucose effectively. And there are things that can raise insulin levels. So the more weight we carry, the more insulin resistant we tend to be. But women can be underweight and be insulin resistant. We commonly see that with polycystic ovarian syndrome. In fact, about half of the women who have polycystic ovarian syndrome have insulin resistance. And we see that because if you have polycystic ovarian syndrome, you've also got a higher incidence of maturity onset diabetes in later life. And usually there's a family history of that maturity onset diabetes amongst relatives. Raised insulin levels can also mess up some of the hormonal processes that happen in the ovary. So women who have insulin resistance can benefit from weight loss. They can also benefit from drugs like metformin, which helps to sensitize their body to insulin. And so, yes, it can contribute to fertility. Another question, some good questions here. When is surgery used in fertility treatment? Okay, this is something that's close to my heart because one of my interests is actually endometriosis and endometriosis surgery. And I think endometriosis is an example where if you have deep infiltrating endometriosis, endometriosis works in strange ways for fertility. You'd think that it's where we get, sorry, I should mention, endometriosis is where you get lining of the womb occurring outside of the womb, and it can cause pain and scarring, but it can also have what we call epigenetic effects. That means it can mess up your ability to create a healthy lining of the uterus. It doesn't actually change the genetic code, but it can alter your body's ability to read the genetic code and then construct a healthy lining of the womb. That's why women with endometriosis commonly have abnormal bleeding or spotting before their periods, and it makes it more difficult for embryos to implant. So women can benefit from having that removed from excision, but also some women just have so much pain associated with treatment that we have to do it to manage pain. Other women who might benefit from surgery are some women who have particular types of fibroids, specifically the ones that bulge into the uterine cavity, can be particularly troublesome when it comes for embryos to implant. And those ones we will often talk about shaving those fibroids off or excising them hysteroscopically with a little telescope we put into the womb. Other women, it might be polyps, where we can remove the polyps. And other women, it might be just some structural problems in the womb called septums, where the uterus is almost divided in half and there's a thin membrane down the middle. If an embryo tries to implant on that, it just doesn't have the blood supply to be able to handle it, and that can affect fertility potential, and those septums we can divide. There are other ones which people talk about. For example, you might have heard of laparoscopic ovarian drilling. It's a treatment which has been used for polycystic ovarian syndrome, where you actually go and drill each little follicles, and that releases some of the hormones that are there and does produce some ovulation in the short term. But it's a little bit more controversial because it does have, can cause scarring of the ovary, and it's an obvious operation. And then the other one, which I think is really important, is when you have a blocked tube that's full of fluid. So what we call a hydrosalpinx, those women do much better when those tubes are removed. They seem to, if the fluid can't come out the end of the tube, it seems to go back into the womb and almost poisons the water in the uterus. And those women can struggle to fall pregnant even with IVF. But we could probably spend the whole night talking about fertility. In fact, I'm sure some of my colleagues will be talking specifically about surgery. All right, more questions. So after biochemical pregnancy, is there any further testing that needs to be done? That's another really good question, and it's one that we field every day of the week. So the answer to that is yes and no. So I think it's important to look into causes as to why implantation or early pregnancy loss might be occurring, or why pregnancy might not be occurring. Certainly if you've had a history of a couple of those, because the more pregnancy losses or early pregnancy losses or pregnancy failures you've had, the more likely when we look for other causes, like some of the ones I've mentioned, endometriosis, fibroids, polyps, but even sometimes some of the autoimmune ones, like some of the clotting problems, you might find those, and then modifying the treatment next time has a greater chance of success for you. And once again, it's individual, and it's something you need to talk to your specialist about, because if you're time poor and time is not your friend, then I'll tend to look into those things earlier. Another question: how many light cycles can you do in a year? The answer is there is actually no restriction on that. So that's good news. But everybody has a different approach to how they feel about what they can cope with. I mean, it's a stressful process. And so there's the physical attributes, and there's also just how you're coping with it as a couple, mentally or as an individual. Next question. What is the likelihood of falling pregnant with no tubes with IVF? Well, in fact, that's a good question. The reality is that if you don't have tubes, you've got the same chance of falling pregnant as anybody else with IVF. It's very good. In fact, IVF was first developed as a treatment for women with blocked or absent tubes. We see that not so as frequently these days because We now have really good tests to pick up early pelvic infections, which are one of the causes of losing tubes. But that was what it was first developed for. So IVF is actually really good at helping women fall pregnant. The only rider is, as I said, if you've got a blocked tube and it's full of fluid, then that probably does need to be removed. It can make it more difficult to fall pregnant. Now, next question is, with a donor of embryos, do we need a referral for the donor or the receiver only? So I guess that question is around donor embryos. Just so everyone knows, for women or for couples who cannot fall pregnant using their own eggs, it might be that they've lost their ovaries for whatever reason, or they've been removed or they've been damaged, or just their ovarian reserve is so poor that the chance of falling pregnant with their own eggs is very low. They can look at using an egg donor, and that's where a woman donates an egg and they're fertilized with a partner's sperm, or we can use donor embryos. And donor embryos are a very special gift, and that's where couples or women have undergone fertility treatment, have maybe completed their own family and still have embryos in storage, and they choose to give those ovaries to another couple or a woman to achieve pregnancy. And the answer is yes. We do need to see the donor as well, because as the treating clinic, we need to go into a lot more depth about the genetic background, organise the specific screening blood tests and genetic screens for the donor couple. And they need to also be counselled by our counsellor and understand the legislation surrounding donor embryos and the fact that there is a central register for donor material. So there are that's a longer answer. The short answer is yes, they need referral. Now, how are we? I've got a little question here. So this question is about just fertility treatment after weight loss, and that's, once again, it's a really important question. I'll just read out the question. It says, my specialist did 6 clinic cycles, and I'm not sure if that's actually collection cycles, and 4 FS cycles of ovulation induction without success, and then told me to lose weight. We didn't have any tube scans, now lost 30 kilos and wondering, should we look at getting more tests done? Yeah, and it says strange because on my ovaries, the internal scan was too far away and the external scans were better. Just on the scans, when I mentioned about the internal scan, the actual little transvaginal probe has, once again, it's got a high frequency, but it's really good at seeing detail over a short distance. And sometimes that doesn't work for everybody. And especially if you're carrying a lot of weight, sometimes those ovaries can sit quite far away from the vagina. It makes it really, really difficult to see them with transvaginal scan. It also makes it almost impossible to do egg collection sometimes too, because to do an egg collection, we have to be able to get that vaginal probe right next to the ovary. And sometimes during the process of egg collection, we can actually push, we can manipulate things in theatre because we've used snoozy and it's comfortable, and we can actually move the ovary where we need to, and sometimes we can't. So that's the reason why that abdominal scans were more useful in that case. Losing 30 kilos, absolutely fantastic. That, in terms of improving your chances, it improves them out of sight, and it must be just wonderful. So well done. Yes, it probably is worth visiting some of those tests, because you might find that previously they just weren't able to do some of them. They may not have been able to assess tubal patency. And realistically, it's almost like a blank canvas. So yes, I think they probably will investigate things further. But certainly if you need IVF fertility treatment, your chances are much, much better. So that's great. Oh gosh, I've just had a couple of beautiful messages from some of my patients. So thank you very much. Just a message about one of my patients, I won't mention the name, who has a 9-year-old. It's wonderful. Thank you for that. Okay. Another question was, is the egg collection surgery a painful procedure? The short answer to that is no, it's not. But once again, it's individual. So I mentioned to you before that we do a blended model at the Hunter. So we do low stim and we do egg collections under some just oral sedation, local anaesthetic. But it's really important to select people properly for that. So women who have had bad endometriosis or adhesions are not suitable for that, because it needs to be a very comfortable procedure. But I can tell you the majority of women selected properly, and we're not collecting stacks of eggs, we're stimulating quite mildly. They'll chat through the procedure, they'll watch the whole thing, it's over before they know it, and they're really very comfortable. It's surprisingly well tolerated. In the operating theatre, we have an anaesthetist present who will give you as much or as little sedation as you want and pain relief, and it's really tolerated incredibly well. So I think you need to be reassured that for the vast majority of people, it's not painful. Now, there always will be exceptions. And I think for women who have lots of follicles collected, they will have more discomfort afterwards. And that's because when you actually drain those follicles, some of them will fill up with blood, and they'll just give you some, but we give you painkillers after that. But really, with the modern sort of anesthesia with good selection, you won't feel anything during the egg collection. So let me have a little look at time. I think we've gone 7 minutes over our allocated time. I'm really happy to answer any more questions, but I think we've probably covered quite a bit of ground. I've certainly enjoyed presenting to you all, and I've really enjoyed all of your questions, and thank you so much for all those good wishes too from my patients. I mean, look, I'm privileged to be able to work in this space, and it's an honour to look after, to be involved in your care. I know you as patients bring us as fertility specialists into the most personal parts of your life, and it's a privilege. Any other questions? Oh, hang on, I've got one more there. 2 failed FETs, 2 miscarriages previous to IVF. How long to wait before more testing for autoimmune problems? Look, I think this is something that you need to talk to your specialist about. Personally, I think if you've had 2 miscarriages and 2 FETs, it's very reasonable to look into other causes. And there's a whole spectrum of things that you can look into. And it's a pretty soul-destroying thing when things aren't working. And I probably look into things early. But once again, with all of these sort of treatments, they are they're options. And you are involved with us in discussing options and deciding which way you want to proceed. So look, once again, thank you so much for participating in this Facebook Live. I've really enjoyed doing it. There are plenty of places where you can find more information. We have our 1-800 number, which is 1-800-111-483. And of course, the IVF Australia website, where you can find, you can always find answers to questions. The other thing is, of course, that these Facebook Lives we're running very regularly, and they're a great opportunity to just ask those questions that that might pop up that you just need some resolution around. And I think for all of us, the question time is probably the most useful. So thanks once again for sharing the last half hour with me, and have a really safe and a great evening, and hopefully we'll catch up again sometime. Thank you.